கத்தாம பார்த்துக்கோ. So good evening, friends. Welcome. Today we are going to have the INI CET surgery questions discussion. So very interesting paper. Let us start discussion now. Hope I'm audible and audio, video, everything is fine. I'm also seeing on another YouTube channel. Okay. Just a few more minutes, we will be live. So when you ask about the INI CET paper, we had around 20 questions from surgery. So of the 20 questions, around 10 questions are repeat questions. So 10 are repeat questions, which are being asked previously also. So 10 repeat, direct repeat. And 5 are totally new questions, totally new concepts. So totally 5 new concepts have come. That means which has never been asked in any of our exam before. And 5 is related questions. So 5 related questions are there. So please remember the 20 questions we are going to discuss now one by one. So of the 20 questions, 10 is direct repeat, 5 is new concepts, and 5 we had related questions. So let us start the discussion. So I as our textbook and as our material, I'm going to go step by step. Section A, general surgery and trauma related questions. Let me start now. So this is a totally new question. So far this question is not asked in any of the exams, and I'm sure most of the students might not know the name of this incision. What is the name of this incision shown here? Yes, what's the answer here? Can you tell me? So those who have appeared for INI CET exam, you might feel this question is totally new, which has not been discussed in Bailey or Sabiston or Swartz, any of the books. It is a totally new update. So some questions in AIMS are actually made not to test whether you know that or not. 99% of the students may not know the name of the incisions. It is mainly a step down question. So it's a question where you have to step back. Step back question means nothing but a question which you should never attempt. If you attempt, you will definitely get a negative point. That is the meaning of the step back question. So this is a step back question, a new updated point in this exam. So when you're appearing for AIMS, you know very well, nobody is going to get 200 out of 200. So definitely the highest score is going to be 170 or 175. So 25 questions are going to be new questions and totally going to be a new concept. So this is a new question asked in the exam known as, yes, what is the name of this incision? Please remember, this is modified Gibson incision. So these are the various incisions we have in the abdomen. So I hope all of you know this incision. This is a right subcostal incision known as Cocker's incision. All of you know that it is used for cholecystectomy. And when I extend this right subcostal to the left side, it is known as rooftop or bucket handle or chevron incision. Chevron or rooftop or bucket handle incision. An incision opening on either side like a V-shape incision in which we can approach the pancreas. This is used mainly for pancreas surgery. So Cocker incision is mainly for gallbladder surgery. A new update in Bailey and Lowe. This is a new incision made in Bailey looking like a Mercedes-Benz. So this is a Mercedes-Benz incision used for liver surgeries. Mercedes-Benz incision used for liver surgery. So Cocker, right subcostal, chevron, rooftop incision, Mercedes-Benz incision. There are 3 incisions on the abdominal wall. You should not forget the common incisions. And this is a midline incision, this is paramedian incision, all these you know very well. This is a new incision. Gibson incision is an incision made parallel to the inguinal ligament. So this is an inguinal ligament. We make it parallelly, little higher up incision. That is known as Gibson. So this is mainly, Gibson incision is mainly used to approach the ureter. So ureter, actually nobody is now using Gibson incision. We are all now using this modified Gibson incision, slightly curved incision like this, mainly used for ureter approach. So ureter approach, we use this modified Gibson incision. Please don't forget. And number 1, Gibson incision, and this is well known. Number 1 is fan and steel, and this is Gibson incision. I request you to please remember the new incision updated this exam. There is other one question known as Maillard incision. So this question can come for next year. It is a transverse incision in the lower abdominal wall. You can see 2 is a transverse incision in the lower abdominal wall. So lower abdominal transverse incision. known as Maillard. So Maillard, Gibson are two updates this year in new questions. Maillard incision is a lower transverse incision and Gibson is a curved incision for ureteric surgery. Okay, so don't forget Maillard incision and Gibson incision. So there are some more incisions mentioned. We will discuss all those incisions one by one now. So this is another incision to go for spleen surgery, pancreas surgery and all. We make an incision like this, like a T-shaped incision. So it's like a T-shaped incision known as Marvidal incision. Since they have asked a peculiar incision, in future they may get questions from this type of incision. So hereafter it becomes a repeat question. So Marvidal incision is the incision made like this. It's an incision like this. The problem is this T-shaped area becomes weaker here. So this area becomes weak. Therefore, to prevent this, they have made a small incision known as B1 incision. So B1 incision is like this. So B1 incision and this Marvidal incision, all these are other types of incisions. So please remember this is another type of incision. So these are all some incisions used for various surgeries, but they may not ask you all those things, but please remember these are other types of rare incisions used for spleen and pancreas approach. Spleen, pancreas and all, we use this B1 incision and Marvidal incision. B1 and Marvidal. B1 and Marvidal incision are two incisions. So the major advantage of B1 is there is no, that T-shaped, that junction is not there. So that will not be a problem of weakness. Okay. So there is another incision. So I hope already I told you this is a Cocker's incision for gallbladder. So see, for gallbladder, we have other incisions like this. One incision is going like this. So it's like a, on the right side, we have a curved incision and another one just opposite to Kerr incision. So this is Kerr's incision. Reverse Kerr is also known as Robson incision. Reverse is Robson incision and another is Mason incision. So Mason, Robson, Kerr, Cocker, all are used for same purpose. Cocker, Kerr, Robson, Mason, all are used for bile duct surgeries. Please don't forget choledochoduodenostomy, choledochojejunectomy, and cholecystojejunectomy. In all these places, we use these rare incisions. To be frank, many surgeons also don't know these type of incisions. Even I have not put any of these incisions like Kerr incision, Robson, Mason, none of this I have put. We always use Cocker incision. That is why these are a rare incision. They are not updated in any new edition of the books. So these are olden days used incision. So don't forget this MCQ this year. That is Gibson incision used for ureter is a parallel inguinal canal. It runs towards the upper part. Okay, that is a Gibson. And new transverse incision in the lower abdomen instead of fan and steel is called as Maillard. Okay, Maillard incision. So for appendix, you know the various incisions used. This is the number one commonly used incision known as gridiron incision or MacArthur or McBurney. So MacArthur or McBurney incision. And this is what we call it as horizontal lanes incision. It is also known as Davis-Rocky incision. So Davis-Rocky is an horizontal incision. And this is a perpendicular incision for a difficult appendix. We call them as Battle's incision. It is not paramedian, okay? It is not running paramedian. It is a little more towards the McBurney's point. So vertical incision towards the McBurney's point is known as Battle's incision. So Battle's incision and all is no more done. Battle incision is at all no more done, just for completion. So remember, appendix incisions are Lance, Battle, Gridiron are the various incisions used for appendix. So now another interesting question. So repeat, it's actually a repeat concept being already asked in exams. A patient had a chest trauma, emergency open thoracotomy done. So comes under which category of wound? So open thoracotomy, emergency open thoracotomy comes under which category of wound? Very interesting question. So you all know there are 4 classification of wound: clean wound, clean contaminated, contaminated, and dirty wound. So there are 4 types of wounds we have: clean, clean contaminated, contaminated, and dirty wounds. So clean wound examples are hernia surgery, thyroid surgery, breast surgery. All this will come under clean wounds. So the wound where we open the cavity, for example, I am going to open the stomach for doing a GJ. I am going to open the, I'm going to cut an acute appendicitis. I'm going to cut the appendix. So where I am going to open like GJ and all will come under clean contaminated. So contaminated is like colorectal. Colorectal anastomosis comes under because it is more of bacteria. The colon contains more bacteria. So colorectal anastomosis Even if it is going to be opened by me, electively opened colorectal also is coming under contaminated. And perforation cases, any perforation will come under contaminated cases. So please don't forget, very important, contaminated includes open cardiac massage, open thoracotomy and open cardiac massage. So the question is actually emergency open thoracotomy and cardiac massage. Open cardiac massage comes under what category? The answer is contaminated. So this is directly from SWATS, direct MCQ from SWATS. Please don't forget, clean wound has an infection rate of 1 to 2%. Clean contaminated, like elective GA surgery, 2 to 9%. Contaminated wounds like colorectal surgery is 4 to 14%. Clean contaminated 3. So they are saying colorectal surgery, it's now getting more contamination. They are in between clean and contaminated. So probably the infection rate among the clean is which is highest is colorectal surgery. So contaminated wound includes the various things like penetrating trauma, large tissue injury, enterotomy during bowel obstruction. All this comes under class 3. Class 4 is perforated diverticulitis. So diverticulum, which is perforated, comes under class 4. So according to the wound percentage, the percentage of surgical site infection increases. Okay, this is a basic thing. And direct line, please don't forget, clean wound is a wound in which there is no infection is present, only the skin microflora contaminate the wound. So please remember, it is a skin microflora which contaminate the wound is class 1 wound. Class 1D is, what is this 1D? It's a new update in SWATS. 1D is a wound which is having prosthesis being kept. So mesh, hernia repair with the mesh comes under 1D classification. Please remember, class 1. Clean contaminated class 2, in which a hollow viscous such as respiratory tract, alimentary tract or genitourinary tract is opened by me under controlled circumstances without spillage of contents is class 2. So in class 2, please remember, while elective colorectal cases have classically been included as class 2 cases, the documented infection rate is high in even elective colorectal surgeries. Okay, please remember, among the class 2 wounds, which is having highest infection means it is colorectal surgery. Contaminated wound includes, what is contaminated wound? Which is open accidental wounds encountered early after injury, like introduction of bacteria into a normally sterile area in the body due to major breaks, like open cardiac massage. So this is a direct question. So gross spillage of contents from the intestine or incision through an inflamed appendix or non-purulent tissue, because purulent tissue comes under category 4. So please don't forget, it is open cardiac massage comes under category 3. So category 4 type of wound is a purulent material, presence of purulent material, perforated viscous with a high degree of contamination. All this comes under dirty wounds. Okay, please don't forget, this is a repeat question. I'm sure most of you would have made it correct. So class 2, question number 2, a patient comes to you with an open thoracotomy with the cardiac massage done is coming under contaminated wound. Okay. So this is also another repeat question. Laparoscopic surgery was planned for a patient. Patient presented with a bradycardia immediately after CO2. So bradycardia after CO2 insufflation. What is the cause of this? So it is one of the common complications of laparoscopy. The anesthetists will be always very much alert with this type of complication. What is this complication? Yes, anybody? What is the complication shown here? Laparoscopic surgery was planned for a patient. Patient developed bradycardia immediately. So bradycardia due to air embolism, vascular injury, peritoneal stretching, metabolic alkalosis. What is the correct answer? Yes, what's the correct answer? It is due to, it's also another question directly from SWATS, page number 456. It's peritoneal stretching. Okay, please don't forget, it's a repeat question. Peritoneal stretching. Okay, CO2. This is a question directly from SWATS. Carbon dioxide, when it is inflated, it causes peritoneal distension, which results in vagal reaction. And because of vagal reaction, there is decreased pulse rate, bradycardia. Okay, so and there is altered venous return that results in decreased BP. Okay, systemic problems include, because of CO2, there will be hypercarbia, acidosis, increased afterload, and increased catecholamines. The catecholamines are increased myocardial stress testing. So there is both local and systemic effects. Please don't forget, it is not air embolism. Air embolism will immediately present with hypoxia, not with bradycardia. Whenever you see an air embolism, it will not cause bradycardia. It is bradycardia. The question is very clear. The line from SWATS, The most common arrhythmia created by laparoscopy is bradycardia. A rapid stretch of peritoneal membrane often causes a vasovagal response with bradycardia and occasionally hypotension. So this if the patient is going for severe bradycardia, we have to give them atropine and we have to let out the gas. That's a very basic question. So don't insufflate more, wait for CO2 insufflation, and we have to give atropine for such bradycardia cases. So atropine is used for severe bradycardia by the anesthesia. Actually, it's not only a surgery question, it's also a part of anesthesia question. So bradycardia during laparoscopy is due to peritoneal stretch causing vagal stimulus. So 3 questions only came from the general surgery. So very much upset seeing that there is no question in trauma this time. Very bad that they have not asked more questions from trauma this time in this exam. So totally upset seeing the paper. And the number of trauma questions are very less. Usually we get a lot of trauma questions. I don't know why they didn't ask any trauma question in this chapter. Okay. So let me discuss the second section, that is on section B. So hope you have understood the 3 questions, common 3 questions. The 3 questions are asked in general surgery. One is from the laparoscopic peritoneal breach, peritoneal stretch causing bradycardia, number 1. Number 2, the question on a new question, new update. It's also a step up, step down question. So don't try to attend such type of questions which you don't know the answer. So the incision question is asked as Gibson incision. Okay. So now coming to section B, head and neck, thyroid, breast, and hernia. This question is a repeat question, directly repeat question. I hope most of you would have answered. Luminal A breast cancer is the most common type of breast cancer in molecular classification. It is the most common type, and it is a type with the best prognosis. It is a type with the best prognosis, and it is associated with, what is the correct answer here? Yes, actually I have typed wrongly. It is ER/PR positive, HER2 negative, KRAS decrease. It's table, this table. Okay, this is a direct table from Bailey and Love. So please understand the table. Luminal A type is ER/PR positive, HER2 negative, Ki67 low. And luminal B is also same. ER/PR positive, HER2 negative, Ki67 is high. So please remember this direct 2 lines. Luminal A type is the most common type. Okay, basal type is a type which is triple negative, ER/PR negative, Ki67 is high. HER2 type is HER2 positive, Ki67 is high. And there is one more type, claudin low, where claudin type is low. So in this, which is associated with BRCA2 mutation. BRCA1 mutation, it is commonly associated as basal type. Basal type has BRCA1 mutation, and it is a worst prognosis. So please don't forget, luminal A has the best prognosis. Remember, BRCA1 all negative, ER/PR negative, HER2 negative, only Ki67 is high. It is having the worst prognosis of all the cancers. It is a clear-cut, straightforward repeat question. So I hope you have no doubt. And there is another question from HER2, which is a pathology question related to staining. It is not a surgery question. Hope you will recall it in pathology. So Mrs. Gupta presented with a carcinoma breast having liver mets. See, very important question. So there are cancer breast alone, non-metastatic. The question should be very clear. Non-metastatic cancer breast or a metastatic cancer breast. What is the best prognostic factor? Please understand, for a non-metastatic breast cancer, lymph node status is the correct answer. Is the decision. So non-metastatic cancer, lymph node metastasis decides the prognosis of the patient. Whereas a liver metastasis, already there is a liver mets, it is ER/PR status decides the prognosis. So it's ER/PR status will decide the prognosis of the patient already if there is a liver mets. So ER/PR status is very important for liver mets case. So non-metastatic case means lymph node status. So the question, I don't know whether the question had a liver met. Some students told that the question had a question of a patient with a cancer breast and metastasis. If metastasis is the question, answer should be ER/PR status should be the best answer. In the question, if there is no metastasis mentioned, you can go for lymph node status. So it depends upon the question. If you have read the question very carefully, if the question has mentioned the metastatic cancer breast, answer should be ER/PR status. Because anyhow, the patient is going to die in next 6 months to 1 year, and there is already a liver met. So such patients, that survival can be extended if ER is positive. That is the concept, okay? If ER is positive, we can extend the survival by giving more better drugs. So this is a new update in 28th edition Bailey. So 28th edition Bailey table says prognosis of the tumor depends on size, stage, axillary node, grade of the tumor, histopathological variant like HER2 negative, lymphovascular invasion, high Ki67 index, extensive DCIS. These are disease factors with the bad prognosis, younger age, premenopausal, BRCA, family history, prior history of breast cancer, obesity, failure to attend the complete the treatment. And one new update is Nottingham's prognostic index. There is a new update. Please don't forget Nottingham's prognostic index. It is already an old concept, but it is not mentioned in Bailey. But this time they have mentioned, including the values has been mentioned in Bailey this time. So it depends on size of the tumor. Okay, it depends on size of the tumor, lymph node numbers, number of nodes. So minimum number of nodes that should be removed in cancer breast is how much? Yes, can you tell me minimum number of nodes to be removed? Size, number of nodes, and grade. So based on these three, we have a grading now. That is known as Nottingham's prognostic index. So Nottingham's prognostic score, less than 1 is good, excellent score, 2, 3, 4, 5, like that. That score is being updated in Bailey and Love. So especially final year students, those are preparing for cancer breast, for a clinical examination, please go through this Nottingham's prognostic index based on the size of the tumor, number of nodes removed, and grade of the tumor. So it is usually, this can also come for your exam in NEET PG. So Nottingham's prognostic index includes the following: size, number of nodes, grade. Okay, so this is a Nottingham's prognostic index. Please go through this index, very important for your exam. So minimum number of nodes that should be removed in cancer breast is how much? Minimum nodes that should be retrieved should be 10 nodes. The number of nodes that should have been removed is 10 nodes. Okay. So this is again another repeat question. So these are all repeat questions. You all very well know they are all direct repeat questions. A patient developed thyroid storm. Okay, thyroid storm. You know what is thyroid storm? It is a patient who was inadequately prepared for surgery, suddenly goes for high output of hormones while planning for a surgery. Which of the following drug is not used? So I used to tell D, D, D. So diuretics, digoxin. So please remember, and DEXA, like steroids. These are three important drugs, D, D, D. So diuretics should be given, digoxin should be given, steroids like hydrocortisone will be given. So some steroids should be given. So these are three important drugs that will be given. So diuretics, digoxin, DEXA, because patient will be going for edema, CCF, and what is thyroid storm? Thyroid storm patients will develop congestive cardiac failure, edema, and they can go for renal failure. So for such patients, we have to go for arrhythmias. So to maintain all these problems, we have to give D, 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 3D. And we have to give the three drugs we use in thyroid. What are the three drugs we use in normally we use in thyroid? The three drugs normally used in thyroid are, so what are the three drugs commonly used in thyroid? Number one, sorry, it's not working. So drugs used like Lugol's iodine, anti-thyroid drugs like Lugol's iodine will be used, and what else? Lugol's iodine should be used, and you can see Lugol's iodine, propranolol, and adrenergic blockers. All this will be used. That is a small issue. Sorry. Why it's not working? So please remember, what are the drugs that will not be used? Some issue, just the pen is not working. Once again. So you can read from here. This is from Bailey and Love, direct paragraph. Intravenous fluid, cooling the patients with ice pack, administration of oxygen, diuretics for cardiac failure, digoxin for atrial fibrillation, intravenous hydrocortisone. That's why I told you 3D. So in fact, you can add 4th D as diazepam, sedation. So diazepam, digoxin, some steroids like dexamethasone or hydrocortisone, like that you can remember. Okay, some steroids will be added, and we have to give the 3 commonly used drugs like carbimazole, Lugol's iodine, and propranolol. All these are given by IV method. If possible, you should give iodine by IV method, propranolol and carbimazole. All these are given by IV method. So please don't forget, which is not used as aspirin. So paracetamol is infused. For fever, we can infuse paracetamol. Iodine, paracetamol, propranolol is used. We don't use aspirin. A simple, straightforward question. So that's a simple question. Don't forget. A patient now presented with non-reducible swelling below and lateral to the pubic tubercle. X-ray of the patient is shown below. What is your diagnosis? So you can see a patient having multiple air fluid levels. It's a picture showing you multiple air fluid levels are seen. So multiple air fluid levels means there is an obstruction. So no doubt. So patient is having a bulging below and lateral to the pubic tubercle. So below and lateral to the pubic tubercle is always femoral hernia. So I hope you know the anatomy of the femoral hernia. So please don't forget the anatomy related to hernia. So this is a typical anatomy. This is pubic tubercle. This is a above and medial to the pubic tubercle, you have superficial ring. Below and lateral to the pubic tubercle, you have femoral ring. So below and lateral to the pubic tubercle is femoral ring. So hernia coming and obstructed at this place is called as obstructed femoral hernia. So the question is very clearly saying there is an obstructed hernia below and lateral to the pubic tubercle. So it is a case of obstructed femoral hernia. So answer is C. So the answer for this question is C. So this again an applied anatomy question. The fibers of internal oblique contribute to which component of the inguinal canal? All these questions are directly from Bailey and Love. You can see Bailey and Love, page number 1065. This question is directly there. So classical question is the boundaries of inguinal canal. This is conjoint tendon. This is conjoint tendon. And this is inguinal ligament. So conjoint tendon is made up of internal oblique and transverse abdominis. So you know very well, conjoint tendon of internal oblique and transverse abdominis forms the roof. That is forming the roof of the canal. So this is the canal. So roof of the canal is formed by internal oblique. Internal oblique contribute to which component of the canal means it is a roof of the canal is formed by internal oblique. So please don't forget, this is a simple straightforward question. So in this general part, if you see, all the 5 questions are very straightforward, simple and easiest questions. So from breast, thyroid, and hernia, all the questions are very simple. The only point is we didn't get a trauma question more in this section. Okay, so very good, Nitish. That is correct. It is from the roof. That is the roof of the canal. So now only one question came from gastrointestinal tract, GIT. So one of the major topics you know very well. Usually from GIT there will be more questions in AIIMS. GIT and trauma will be the most important topic for AIIMS, but this time they purposefully avoided questions from these 2 sections. Therefore, there is only one question. That too is also a physiology-based question. Pentagastrin stimulation test. What is this pentagastrin stimulation test? What is the use of this? See, please remember, normally we have a basal acid output. And after this pentagastrin stimulation, we have a maximum acid output. So basal acid output and maximum acid output following a pentagastrin infusion is called as maximum acid output. So basal acid output and maximum acid output, how does it vary? That based on this table. So normally basal acid output is 0 to 10 millimoles. Maximum acid output is 7 to 45 millimoles, and peak acid output is this. So now, if I am going to give this pentagastrin, gastrin secretion is collected every 15 minutes for next 1 hour, and you can see the increase of maximum acid output. The question is where it will not increase. So who will not get increased acid output? That is a simple question. So who will not have increase of acid after giving pentagastrin stimulation? So please don't forget gastrinoma, it increases. Okay, gastrinoma, it increases. In this table, this is a table, classical table. You can see pernicious anemia, there is hypochloremia. Hypochloremia means decreased HCl. Even on stimulating by pentagastrin, pernicious anemia will have decreased HCl. Partial gastrectomy patients, partial gastrectomy also, there is no way for HCl. So HCl is decreased even for those cases. So then who will have increased of increase of HCl on stimulus by pentagastrin. This, please don't forget, this is a very simple question, but it is a very important question. Duodenal ulcer, gastric hyperplasia, carcinoid tumor, gastrinoma, men, all these cases will have increased acid on pentagastrin stimulation. Repeatedly, they will only ask you pernicious anemia and partial gastrectomy patients will not have increased acid. So don't forget this question. So it's a very old concept. It means it's not a common question asked. It is very old question. In 2000s, this is a very commonly asked question. But after that, it is being outdated and nobody is doing this test. So it is not even there in Bailey and Lowe or Sabiston. But for now, they have asked this question again, means you should think about it and you should remember it. It can be a future MCQ also. So it is increased in gastrinoma, increased in duodenal ulcer. It is decreased in pernicious anemia. So please remember, who will have decreased acid on pentagastrin stimulation is pernicious anemia. Okay. So only one question came from GAT. There is no question from esophagus, colon, rectum, anus. None of the questions came from this section. And the most important thing is in this exam, this is one of the most toughest section being asked. So this section is completely a high number of questions came from hepatobiliary and pancreatic. So bile duct injury with the blood vessels in the hilum is given the name of the classification as dash. Tell me what is the name of the classification of blood vessels in the hilum. See, this is a classical question. You should not forget. This is a totally new question. So this question is again a step down question. Step down, I have already told you, step down means don't try to attempt this question. So most of you will be stimulated on bile duct injury. Okay, it's a bile duct injury means it is Strasbourg classification. This is what most of you will be thinking. So bile duct injury means Strasbourg. So let us attempt like this. Even many faculties I saw in many recall videos, they were answering that question as bile duct injury is Strasbourg classification. It is totally wrong. So this is not a NEET PG question at all. It is it's an SS question. Super specialty entrance question. It's a very commonly asked super specialty entrance question. Already in super specialty entrance in AIIMS, this question has been asked many times. The question is not Strasbourg. Strasbourg is only for pure bile duct injury. Bismuth is for bile duct stricture. They both never talk about vascular injuries. That injury which talks more about vascular injury is Hanover classification. It is not from your common books. It is from Bloomgard. So Bloomgard and from Mango. So these are the books which are explaining about this classification. Stewart is another classification. It is also a laparoscopic bile duct injury. See, Strasbourg is for bile duct injury either by open or lap, but Stewart's is pure laparoscopic surgery bile duct injury. So 3 classifications. I'll show you the image. So please tell me what is this image showing you in this classification. So this is a stricture more than 2 centimeter from the hilum, less than 2 centimeter from the hilum, at the hilum, and separated duct and aberrant duct. So this is a classical question we have already discussed many times. Bismuth strictures. Bismuth classification of bile duct strictures. Okay, this is very simple. Bismuth classification of bile duct strictures. This is a common MCQ. All of you know this is investigation based on MRCP. MRCP classification of bile duct strictures is bismuth. And this classification, all of you know, this is an ERCP classification of bile leak. ERCP classification showing you bile leak. So this is one question which is commonly asked, and many times you all will be stimulated to answer this question only. It is Strasbourg classification of bile duct injuries. Please remember, it is not Strasbourg. The question is not asking Strasbourg. So AIIMS examiners are not going to ask such a superficial question. Even in FMG exam, they are going to ask the grading of the Strasbourg. In AIIMS exam, they won't ask you superficial like what is the bile duct classification. Please have that in mind. It is not going to be so easy. So Strasbourg classification of bile duct injuries. A is cystic duct leak. B is aberrant duct. Aberrant duct is clipped. C is aberrant duct cut. D is lateral injury of bile duct. E is circumferential injury of bile duct. In fact, E is having E1 to E5. So this is a very common MCQ asked in the exam. So please remember, this question is not asked in the exam because it is a pure bile duct injury. From the picture you can see it is a pure bile duct injury and sure shot MCQ for NEET PG exam. Strasbourg is a sure shot question for NEET PG exam. But the question asked for your exam is Stewart's way. What is Stewart way classification? Stewart way classification is purely for laparoscopic injury, not for open injury at all. So class 1 is an injury which is incompletely cut the bile duct. I have cut the bile duct incompletely. Class 2 is a lateral damage of common hepatic duct. You can see common hepatic duct is injured. In the first one, common bile duct is injured. Here it is common hepatic duct is injured. So both are lateral damage. 3 is an injury which is involving most common, where the most common laparoscopic injuries. Class 3 injuries are the most common laparoscopic injuries in which we are going to cut through and through full transection of CBD and a variable portion of proximal duct. Class 4 injury is a damage of right hepatic duct completely. You can see completely transected the right hepatic duct. So here, if at all you want to, you can answer Stewart way, maybe one of the answers. Many had concurrent right hepatic artery injury. But class 4, they didn't mention about the artery, but they are telling many had right hepatic artery injury also in class 4. But in this also, they are not mentioning more about the arterial injuries. It is therefore Hanover classification. Hanover classification is a classification of bile duct plus vascular injury. This is a very commonly asked super specialty question. It is never being asked in NEET PG, and this is definite step down question in this AIIMS exam. If you have marked Strasbourg, it is going to make you go wrong. So the answer Strasbourg, whoever marked Strasbourg is wrong. So this is a Hanover classification. So A is peripheral bile leak. It's a totally new question. Nowhere you would have read this question in your standard books. So type A is a peripheral bile leak, like cystic duct leak or leak in the gallbladder bed. Type B is a stenosis of the main duct without injury, like clipping, incomplete or clipping. So you can see B is like, it is like Strasbourg. Strasbourg A is cystic duct leak. Strasbourg B is clipping. Same thing it comes. C and D includes vascular injury also. Vascular injury is included in type C and type D Hanover. See, I'm telling you, no need to remember this. I don't think this will be again coming for any exam. Only the name can come because it is not from any of the standard books for PG exams. It is a super specialty question. So tangential injury of the common duct with the D is hepatic artery, S is left hepatic artery, P is proper. So according to the hepatic artery, you have the classification. So hepatic artery injury is included in Hanover classification. So E is another circumferential injury. Okay, E is a circumferential injury, is E. Just remember this Hanover is a classification of bile duct and vascular injury. And this question is again a repeat MCQ. I'm sure most of you would have answered it correctly. A patient underwent laparoscopic cholecystectomy. Specimen had a carcinoma gallbladder invading up to muscularis propria. Muscularis propria. What is the T staging? Answer is T1B. There is no submucosa. So T1A is mucosa. T1B is muscularis propria. T2 is serosa. So these are the three things you can get in specimen. So what is the correct answer for this question? Anybody? What do you think the correct answer in this? So you should ask the pathologist to tell more finding. What is it? Tell me about the cystic duct margin. You should ask her about the cystic duct margin. That is the correct answer. See, you should not forget this basic concept. So there are, because the gallbladder management further depends upon the staging. If the laparoscopic cholecystectomy specimen comes as T1A, tumor involving mucosa, that lap cholecystectomy is enough. What you have done already is enough. For a mucosa only tumor involved, laparoscopic cholecystectomy is enough. For a T1B cases, which is involving muscularis layer. So muscularis layer, you should ask for some question. From the pathologist, you should ask for 3 questions. Whether there is any lymphovascular invasion present. Whether cystic duct margin is positive. Okay, so whether cystic duct margin is positive, lymphovascular invasion positive, or poorly differentiated. Whether the tumor is poorly differentiated, you should ask the pathologist. If the pathologist is telling it is lymphovascular invasion positive, cystic duct margin positive, poorly differentiated tumor, what should I do? Only in such cases, I should go for a extended cholecystectomy. Means 2 centimeters of liver should be resected. I have to reopen and cut 2 centimeters of the liver should be resected in T1B cases. Please remember this. So T2 is a tumor involving the serosa. In such case, you won't ask for any question. Okay, directly we go for radical cholecystectomy. Radical cholecystectomy, you know very well. What is the segments removed? 4B plus 5 is removed in a radical cholecystectomy. In T1B, if all these are negative, already done lap cholecystectomy is enough. Please understand it. So muscularis propria tumor involvement, if lymphovascular invasion is negative, cystic duct margin is negative, it is well differentiated. Such cases, laparoscopic cholecystectomy is enough. If it is positive, I have to redo laparotomy and do extended 2 centimeter resection of the tumor should be done for such cases. Okay, don't forget this question. So the answer for this question will be revise the cystic duct margin will be the best possible answer in this question. So many of you would have done radical cholecystectomy, it is wrong. Please remember, because invading muscularis propria is not the answer for radical cholecystectomy. In such cases, we should revise the cystic duct margin. So if cystic duct margin is positive, we have to go for surgery. Okay, please remember this. The following are the risk factors of carcinoma gallbladder. It is a straightforward repeat MCQ. So those who have read very well for INI CET, you would have correctly answered it. So the risk factors are porcelain gallbladder. Stone size more than 3 centimeter has 10% risk of gallbladder cancer. 10% risk of gallbladder cancer when the size of the stone is more than 3 centimeters. Primary sclerosing cholangitis and polyp size less than 1 centimeter is wrong. So when the polyp size is more than 1 centimeter, it is a risk of gallbladder cancer. So risk of GB cancer is more with polyp size more than 1 centimeter, not less than 1 centimeter. It's a straightforward repeat question. So no need of discussion in that question. So this is again another repeat question. It's being a repeat question from pathology as well as from surgery. Most common mutation oncogene involved in cancer pancreas is KRAS oncogene. It is a straightforward line from Sabiston and Swartz. You can see the straight question. The KRAS oncogene is currently thought to be the most commonly mutated gene in pancreatic cancer, which is seen in 90% of the tumors having this mutation. There are many other mutations also, but KRAS is the most common mutation. Second mutation is P16. Okay, for super specialty MCQ. So it's already an old MCQ from super specialty. First common is KRAS, second is P16 mutation. So this is also a repeat concept, not a straight question. It's a repeat concept. You can easily answer this question very well if you can read it well. So type 1 choledochal cyst as per Todani is a classification you know very well. Type 1 is fusiform dilatation like this. 1A and 1B is involves intrapancreatic part. So both are fusiform dilatation. 1A is confined to bile duct. 1B involves pancreas also, involves intrapancreatic part also. So this problem with the choledochal cyst is it can highly go for malignancy. So high chances of malignancy is there in choledochal cyst. So the most common etiology for choledochal cyst recently found out is anomalous pancreatic bile duct junction. So the most common pathology found is anomalous pancreatic bile duct junction is the most common pathology seen. So there is increased risk of cancer is seen. So treatment of choice is not drainage. Because of the malignancy, I should resect this cyst. I should resect the cyst. So I should do resection is the treatment of choice. So increased risk of cancer is present. I don't know the fourth choice which is being asked in the question. So, but please remember, resection is not the correct answer. We should not do resect. We should not do drainage. We should only resect. So choledochal cyst, most common type is type 1, which is fusiform dilatation. 1A, 1B, both are fusiform dilated cyst. So 2 is a type which is a diverticulum type. So please remember, it mimics like accessory gallbladder. Mimics like accessory gallbladder is type 2. So which type mimics like accessory gallbladder? Type 2 mimics like accessory gallbladder. So least common type is type 3, that is choledococele. Okay, choledococele is type 3, which is having a dilatation at the ampullary area, which is having a dilatation in the ampulla. 4A is A for all ducts dilated, B for extrahepatic dilatation. 5 is Caroli's disease. So this is a repeat MCQ topic. So you have to be thorough with this because it's a high yield repeat topic for your exam. Please go through choledochal cyst, Todani's classification. So these are the questions came from habitability. Habitability really had a very good number of questions with a good number of concepts also. The most bad thing is urology. We had no questions in this exam. Usually urology, see, the most favorite topics of AIMS are not being asked, like trauma, GIT, urology. 0 questions in all this. No questions were being asked from these topics. But specialty, we had some basic questions which are very usual. As usual, they are very easy questions. Bilateral adrenalectomy is a treatment for which of the following? So bilateral adrenalectomy, answer here is 2 cases. One is Conn syndrome, another is Cushing syndrome, Cushing's disease. In both the cases, we will do bilateral adrenalectomy. Not for Nelson, not for Shigan. So they both are not the correct answer. Indications of adrenalectomy. Unilateral adrenalectomy is used for Cushing syndrome involving adenoma of the adrenal gland. Conn syndrome, which produces hyperaldosteronism, also can be due to most commonly adenoma seen. Pheochromocytoma due to adenoma is also we will do unilateral adrenalectomy. Secondary mets to the, like from renal cell cancer, adrenal mets, we will do adrenalectomy. So for bilateral tumors, for hyperplasia, patients involving hyperplasia causing Cushing's or Conn syndrome, and Cushing's syndrome if pituitary treatment fails. So pituitary cause of Cushing's is called as Cushing's disease. So some pituitary tumor producing ACTH can cause continuous secretion of cortisol. So such cases also we go for bilateral adrenalectomy. So in this question, there are either Conn syndrome is an answer or a Cushing syndrome is an answer. So one of these two is answer. So it depends purely hereafter. Some questions, no, it is purely examiner's key. I'll say only examiner's key, or I don't know whether any other catch point is missed in this question. So when you're reading this question, some other catch point, some things are mentioned, like for example, patient having a pituitary lesion, something like that mentioned or not, I don't know. But Cushing's disease and Conn syndrome, we can do bilateral adrenalectomy is a treatment of choice. See, this is another question. We have to be very careful in answering the question. Best diagnostic method for parathyroid adenoma. So most of you would have answered this system EB scan only, either technetium 99M system EB or system EB SPECT. So there are many types of system EB scan. This examiners very carefully placed an MCQ, which to make you more confused in this choice. So system EB scan is the most commonly used. So technetium system EB subtraction image by technetium system EB. Dual radionucleotide substances are used, and subtraction image is obtained for parathyroid adenoma is commonly used. But the problem is this is sensitive. Much better sensitive is system EB SPECT, single photon emission CT. So system EB with the CT scan is used, which is much better than technetium 99M system EB. But that is also not the answer if the question had PET CT. PET CT is the best of all. To locate the best method for parathyroid adenoma location is PET CT. So the answer according to this order is ultrasound neck is less better than technetium 99M system EB. That is less better than system EB SPECT. That is also less better than PET CT. So if the question had PET CT, that is the best answer for this exam. So the answer is a direct line from submission I have made here. The sensitivity of system EB SPECT is 79 for localization of a parathyroid adenoma and 44% for multi-gland disease. So please remember, multi-gland disease, the percentage is 44%. So whereas if you go for a PET CT, see the PET CT. So the sensitivity comparing fluorocholine PET CT was compared with SPECT CT. The sensitivity of PET CT is 93%, SPECT is only 61%. So if the question had PET CT, please go for PET CT. That is a better answer for the exam. Okay. So that is a question again from Burns image. So one of the toughest question is to calculate the Burns image from a partially burnt patients. They won't give a complete Burns case. They'll give a partially burnt case, and finding out this always little complicated, but the question is asked based on the commonly used chart, Lunden-Browder chart, and not on rule of 9. So if you try to answer based on rule of 9, definitely you will go wrong. So this question you should answer based on Lunden-Browder chart. Full circumference of right thigh was mentioned in an adult patient. So full circumference of right thigh is, this is B. Full circumference of right thigh, B is equal to, in one thigh, it is 4%. So full circumference of right thigh was given in the image of the exam. So I will go for full circumference of right thigh means front and back side. So it is 4%. And they mentioned both arms full circumference. So both arms, not full upper limb. So both arms full circumference. So 2% for both arms full circumference. So 2 plus 2. Okay, so 2 plus 2 is for arms. And for chest and upper abdomen, front of chest and upper abdomen, this is 13%. So chest and upper abdomen, it comes to 13%. So the actual value as per London-Browder chart will be 8 plus 13 will be coming around 21% only. So you should use this formula only to calculate the bunch, because this only will give you separate values for each area. So for example, head is having different value at different age group. So in adult, it is 3% only. Head is normally 9% in rule of 9. But see, in adults, in this formula, it is only 3%. In upper limb, you know very well, it is 9 in a Wallace rule, but it is not 9 here. It is totally different. It is 2 plus 1.5 plus 1.5. 2 plus 1.5 plus 1.5. And B and C are different for these patients. Thigh and leg have different values. Thigh is 4, leg is 3. So B is, we have to calculate 4. Okay, please remember 4. Therefore, you have to remember this value based on B is anterior thigh is B, posterior thigh means 4 plus 4, it will be 8. Okay, 4 plus 4, it will be 8. And upper limb, arm alone is 2 plus 2 is 4. So 12 plus 13, it will come around 25%. So I don't know the values, exact choice is given, but you should calculate based on this formula only. It is not Alexander Wallace rule. It is London-Browder chart. So there is an interesting question now. Liver transplant is contraindicated in which of the following tumor? Not advised. See, any cancer, we don't do liver transplant. Please remember, this is question on liver transplant in a recipient. Recipient, whom you don't do. I'm not asking about the donor transplant. So donor transplant, they can give only in few cancers. The two different questions. Don't get confused with these two questions. A donor who can give liver is, anybody can give liver except a patient having cancer. Except what cancer? Except what cancer they can donate means the patients who are having endometrial cancer can donate. Number one, endometrial cancer can donate organ. Number one, endometrial cancer patient can donate. Number two, any skin cancer except melanoma can donate. Number three, any brain tumor can donate. Only 3 tumors can donate organ. Non-melanotic skin cancer. Number two, endometrial cancer. Or number 3, brain tumors. So any patient who had cancer more than 5 years before. Any cancer before 5 years will not have any recurrence now. So any cancer more than 5 years before, brain tumors, endometrial cancers, non-melanotic skin cancers, only these people can donate. But the question is not asking about the donor, it is asking about the recipient. If I am going to receive a liver, I should have not had which cancer? I should have not had any cancer. All the above actually. Answer is all the above. You should have not had any cancer. Sir, where did you find out this answer? Means it is again step down question. I'm already telling you it is a step down question. There are 5 questions, surgery questions, which you should step down. Don't try to attempt that question. They are totally not asked in any of the previous exams, and even many of the recall sessions done by even the surgeons are also wrong. Please remember, this is a step down question. Nowhere we will do transplant. If at all you want to answer, except means only for testicular tumor patients you can do transplant, not for anybody else. So where did I find it? Most centers will offer a transplant when the risk of recurrence is less than 10% at 5 years. So when the risk of recurrence is less than 10% at 5 years, I can do. So how much is the risk of recurrence in colorectal? 18%. Non-melanotic skin cancer, 23%. Breast cancer, 33%. Vulval cancer, 33%. And see this table. So local recurrence rates, because all these cancers will now recur when there is an immunosuppression started. Many of these cancers will recur. Low recurrence rate is seen with uterine cancer, testicular cancer, cervical cancer. I can say it as genitourinary cancers. Thyroid cancer, lymphoma, incidentally detected liver tumors. All the other cancers have more than 10%. So you can see prostate, breast, colon, Wilms, uterine, bladder, sarcoma, melanoma, renal cell, non-melanotic, even non-melanotic skin cancer have more recurrence. So when there is more incidence of recurrence, so most centers will offer transplantation when the risk of recurrence is less than 10% only. So none of these cancers we will do transplant. If at all you can remember, only testicular cancer has low recurrence rate. You can only do for this B, C, D. We should not do transplantation. This is a new question. I'm again telling you, it's a step down question. Never try to attempt this question in the exam. You should leave this question because it is a new concept. Most common primary malignant tumor of children is 100 times asked MCQ. It is pilocytic astrocytoma known as grade 1 astrocytoma. This is the most common brain tumor in children. So this is correct answer. These are all straightforward questions. You should not make mistake in these type of questions. So the most common brain tumor of children is pilocytic astrocytoma. It is usually seen in cerebellar area, cerebellum. It is usually found in cerebellum. Okay, we call it as posterior cranial fossa tumors. Posterior cranial fossa tumors. So don't forget, it is not meningioma or medulloblastoma or neuroblastoma. They are not the correct answers. It is pilocytic astrocytoma. Repeat question. So this again another repeat question. Rolled out cancer in the nose, rolled out margin. You can see rolled out cancer in the nose, also known as tear flow area. It is clear-cut case. Tear flow area. It is a basal cell cancer. Basal cell cancer is the most common skin cancer. It is found on the medial canthus of the eye. So these are all no doubt repeat questions and basic questions. I hope you would have not made a mistake in these type of questions. A newborn baby with a scaphoid abdomen and breathlessness, which of the following is not done? It's not done. So again, what is it? Scaphoid abdomen with breathlessness is a diagnosis of congenital diaphragmatic hernias. You should never do bag and mask ventilation. So no, never do bag and mask ventilation. Put a tube. Ideally, we should intubate and give positive pressure ventilation. You should give, if at all you want to give, you can give nasal oxygen. But don't put bag and mask and give oxygen because it will go and distend the stomach and the baby will go for more breathlessness. So the answer is bag and mask ventilation. So the total number of questions we had from various specialties: general we had 3 questions, trauma 0, head and neck 5 questions, GIT 1 question, HBP 5, urology 0. Specialties we had around 6 questions. So totally around 620 surgery questions we had. So this time unexpectedly there are less image-based questions in surgery, less questions from trauma, and less questions from urology and GIT. So these questions, the final disclaimer, all these questions are not straightforward, direct questions from INI CET exam. All these are questions based on the pattern of questions asked in the INI CET for the teaching purpose. So any similarity found is incidental, and we have not taken any question directly from INI CET paper. So I request you students, if there is any controversy, you can post in the chat itself so that we will discuss it. And you can join in our Telegram, in my Telegram channel, Surgery 6 Sir. You can post your doubts there. You can follow my Telegram channel, Surgery 6 Sir, or you can follow in my Insta channel, Surgery 6 Sir. You can clarify your doubts there. So any doubts you had in this exam? Any doubts you had from the surgery questions in AIMS? Yes, no doubts. So any more doubts we will discuss in my Telegram channel. Thank you all. Thank you all, friends. Thank you. Bye. Please go through these questions again so you can find out the minute twist in many questions which is being asked, which is being not even discussed in many other platforms. You have to go through this and you have to remember these questions for future exams. Okay. So all the best for your exam. Thank you.